Hello everyone, my name is Sausan Mohammed. I'm going to talk about shortness of breath or dyspnea. What is dyspnea? It's a subjective sensation of breathing discomfort or difficulty. Usually the patient comes to complain that he can't take his breath, and some patients go further and complain of that they are gasping for air. It can range from mild awareness to severe respiratory distress, and usually it's associated with medical conditions in most of the cases. It may present as acute, chronic, or intermittent. What is the differential diagnosis? It could be due to some respiratory problems like asthma, COPD, pneumonia, pneumothorax, interstitial lung diseases. Life-threatening conditions include pulmonary embolism and pneumothorax. It can be attributed to cardiac conditions such as acute coronary syndromes, heart failure, pericarditis, or less acute symptoms like valvular heart disease. Other causes can also cause dyspnea, like some systemic conditions like asthma, metabolic acidosis, hypothyroidism. Psychiatric problems are important cause of shortness of breathing, like panic attacks and disorders, and anxiety disorders in general. It can be also due to some musculoskeletal problems like kyphoscoliosis, myasthenia gravis, as a neuromuscular disorder. What would we do if a patient complain or present to you complaining of shortness of breathing? So let's look at the workup. History is very important, as in the consultation, history usually helps us in reaching the diagnosis by like 80 to 90%. Very important to have a detailed, comprehensive history to reach a diagnosis. Try first to identify whether it's an acute problem or a chronic condition. Ask about exacerbating and relieving factors, whether it's precipitated by exertion or at rest or in changing position. Very important to rate dyspnea according to the New York Heart Association classification. I'm going to talk here a bit about New York Heart Association classification of dyspnea in patients with heart failure or dyspnea in general. So class 1, when the patient this classification mainly depends on the patient's symptoms and his functional ability. So class 1, when the patient has no symptoms and he is not affected functionally with the symptoms. So class 2, when the patient has only mild symptoms and there is no limitation or very mild limitation in his functional ability. And when the patient has more symptoms, that is, he is still comfortable at rest, but he has some symptoms with his daily regular activities, and there is some limitation of functional status, then the patient is class 3. And when the patient start to have the symptoms at rest and he become dysfunctional, so this is class 4. Okay, so let's go back to getting back to the workup in the history. Ask about more symptoms of cardiovascular system and respiratory system, GIT symptoms and psychiatric symptoms. Ask about orthopnea, paroxysmal nocturnal dyspnea, chest pain, wheezing, fever, palpitations, dizziness, and loss of consciousness. GIT symptoms are very important because some patients who have GERD can come and complain of shortness of breathing in addition to other symptoms like epigastric pain or chest pain. Anxiety symptoms and panic attacks are important causes of shortness of breathing, and it deserves to be asked about. Ask the patient is his medical history. If he is a known patient, like have a chronic medical condition like hypertension, diabetes, heart disease, dyslipidemia, has any respiratory problem like asthma or COPD. Family history is very important. Ask about premature cardiovascular disease and sudden death in addition to any one of the above mentioned conditions. It's very important also to ask the patient about the smoking history, alcohol use, and illicit drugs, especially cocaine, as because it's a cause for myocardial infarction, especially in younger age group. Smoking is a known risk factor, is a very important risk factor for cardiovascular disease. Alcohol also can cause cardiomyopathy. It's very important to complete the picture of history to include the patient's feelings, his ideas, his concerns, expectations about the disease, and also to assess how is he doing functionally with his symptoms. Moving on to the physical examination, look at the patient's general appearance, whether he is distressed, pale, cyanosed, mark his JVP, and check the vital signs, oxygen saturation, pulse, heart rate, blood pressure. Detailed history, detailed examination, cardiovascular system examination, and respiratory examination, including inspection, palpation, special procedures, and auscultation. Look for deformity, asymmetrical movement, tactile freemitas, wheezing, rails, all these kind of things. Mention also about the heart sounds and if there are any murmurs. Okay, so now we took history, we took examination, and we had a differential diagnosis in our mind. So moving on with the workup, we do some diagnostic procedures, we do some laboratory tests, and some imaging to narrow down the differential diagnosis and reach a definitive diagnosis for shortness of breathing. So what we do is CBC, thyroid stimulating hormone, urean electrolytes, pulse oximetry, blood gases, D-dimer to exclude pulmonary embolism, for example, brain natriuretic peptide, troponin I, if we are suspecting acute coronary syndromes or heart failure, ECG, echocardiography, chest X-ray. If we are suspecting more of a cardiac origin, we can go further to do CT angiography and cardiac catheterization. If we are suspecting some respiratory or pulmonary problem, we can go on according to the diagnosis or the provisional diagnosis. We can go to do like CT angiogram, CT chest bronchoscopy, thoracocentesis, pulmonary function test to exclude asthma or COPD. Other more tests can be done if we are suspecting other causes, non-cardiac, non-pulmonary, GI endoscopy, for example, CT sinus, and more tests to reach other causes of shortness of breathing. So this is the same as what we saw before, basic laboratory test and imaging, and also advanced tests like the advanced imaging, like CT angiography and echo, and these are specialized tests. Okay, so to reach the diagnosis, we have to have a step-wise approach. As we said before, we go to the history, we do physical examination, we order some initial blood tests and some imaging. The most important thing is to prioritize the life-threatening conditions like acute coronary syndromes, pulmonary embolism, and pneumothorax, because these are very time-sensitive conditions, and the treatment has to be started immediately to save the patient's life. It's also important to identify from the beginning if the condition is acute or chronic, after excluding the life-threatening conditions. Okay, moving on to the treatment. So we have general measures to do that manage most of the conditions that cause shortness of breathing, like the cardiac or respiratory problems, oxygen therapy, treating the underlying cause. By that time, we already have a differential diagnosis, or we might have reached the definitive diagnosis by this time. So there are also special measures or special treatments to do. We can give bronchodilators, steroids, for example, for asthma or COPD, obstructive lung diseases, antibiotics for pneumonia, for example, or endocarditis. Patients with acute coronary syndromes can go on further to have nitrates, aspirin, morphia, and they can go further for angioplasty, stenting, percutaneous coronary intervention, or thrombolytic therapy. anticoagulants for patients with pulmonary embolus, diuretics, and diuretics can be done also in addition to other treatments for patients of heart failure. So it depends on the cause and what diagnosis we have reached so far. Other conditions like anemia can be treated with transfusion, and if it turns out to be some psychiatric problem, we concentrate on that and we give the specific kind of treatment, like for example SSRI or selective serotonin uptake inhibitors. Let's take this real life case scenario. 5-year-old male who presents with progressive shortness of breath over 48 hours. It actually started 7 months ago when he noticed that when he's climbing the stairs or when he does any moderate activity, and now it is at rest. And associated symptoms included cough with pink frosted sputum, mild chest discomfort, fatigue, and there are feet swelling. There was no fever, no night sweats, and no weight loss. The patient is a known case of hypertension for 5 years, and he sustained an acute myocardial infarction 2 years ago. His medications include amlodipine 5 milligrams daily, aspirin, atorvastatin, and bisoprolol. His father had coronary heart disease, and the patient is a smoker, and he used to have some occasional alcohol, and he was not using any recreational drugs. On examination, his general appearance, the patient was dyspneic, sweaty, and he is sitting uncomfortable. His blood pressure was 150/95, and the heart rate was 110 per minute. Respiratory rate was 26 per minute. His oxygen saturation was 85%. His temperature was normal. On examination of his pericardium, the patient has is noted to have some muffled heart sounds. The S3 has a S3 gallop was there, and his JVB was raised, and his peripheral pulses are intact. He has bilateral crackles on his both lower lung fields, and there was no wheezing or stridor. His liver was just palpable. His abdomen was soft and non-tender, and he had lower limb edema. The patient was not really cyanosed, and there was no clubbing. His laboratory tests include normal CBC and white cell count, hemoglobin, and platelets. His brain natriuretic peptide was really high. It was 1,200. The troponin was normal. Electrolytes were normal. Chest X-ray showed bilateral pulmonary edema. ECG showed sinus rhythm, sinus tachycardia with no acute ischemic changes. The echo showed global hypokinesia with ejection fraction of 35%. So the working diagnosis was acute heart failure as an exacerbation. It is most likely due to secondary to ischemic cardiomyopathy. So this is a real case scenario that we see every day in everyday life. So as a key takeaway message, shortness of breathing is a symptom. Basically a symptom, it's not a diagnosis. Prompt evaluation and targeted treatments are essential. Always don't forget to prioritize and try to exclude life-threatening conditions like acute coronary syndromes, pulmonary embolus, and pneumothoracis. And I hope guys you benefited from this short video, and thank you for attending, and good luck.